Okay.
And, okay. For the last 5 minutes, I've been talking about non-compliant and incompetent patient. Against medical advice, if the patient is competent, they can sign themselves out or discharge themselves out. And of course, incompetency or competency, a person who is non-compos mentis, meaning to say is they have some incapacitation. For example, if my patient is drunk or is my patient high, are they competent to make any decisions? I'm telling you, there hasn't ever, well, I've had a couple, drunk patient or very high, a patient is very high that says, I want to stay here and I want to help you treat me. Each one of them says, why am I here? Why am I chained up? This is wrong. I'm being held against my will. Help! And why do they always scream? And I always say, help! Help! And you're like, oh, God, here we go. Right? Now, can I release them?
No.
I can't. Many times, sometimes there's some of them are borderline because I'm about to release them because it's good that you're going to release me. There would have been trouble. And then you're like, oh, really now? Now can I release them?
No.
Because now they're giving me the googly eye and they're like, and they already have that precox face. Now, how many times I had that patient just, it's good that you comply with my wishes. On my planet, there would have been hell to pay. And you're like, holy crap, I was about to release this person into the world. How much trouble would I have been in? Again, you have to keep your eyes and ears open, and you have to pay attention. And remember, letting go of my patient who's been in the office takes at least 72 hours. Some offices even up to 5 business days. Duty to treat the patient with AIDS. Right now, let's take a poll. Do we have a duty to treat the patient with AIDS?
Yes.
Anyone say no? Yeah, but they got AIDS.
So?
It can make me sick.
That's why you wear
your gloves.
That's why I wear the gloves, my personal protect, right? Now, here's a
Is that
tricky
like
one.
discrimination or something?
Yes, it is. And also, how do I know? My patient could have the bubonic plague. My patient could have cholera. My patient could have TB. What does AIDS make any difference? It's a disease, just like anything else. Even if my patient has mental disease, I have to help them, even though I don't want to. I love my mother dearly, but I cannot stand her profession. The mental health profession, because what's it full of? Crazy people. People that you don't like dealing with. Yeah, see, you know, you work. Each and every one of them, they're jerks. And they're very difficult to deal with. And those of us who did retail, they're jerks. They're very difficult to deal with. But we have that duty, remember. There's a duty. So, AIDS, HIV, now. Right? Let's, before we start talking about the AIDS patient, let's switch it around. What if I have AIDS?
So?
I'm the doctor. Wouldn't you need to know?
You have to know. You have to know the bias, don't you?
But no, let's just talk just layperson. Let's not,
okay.
Because we're not going to go into the rules yet. But do you think it's okay? Like if I take care of your kid?
No. I think I have to know.
How about, well, even if you knew or didn't know, is it okay?
Oh yeah, I mean, as long as you're good. As long as you don't do nothing crazy.
Yeah, if you're following the proper.
Yeah.
Oh, wow, you guys are, well, I grew up, because my career was in the 90s in New York City at the height of the scare. The majority of the facility didn't want it. When we were deciding on the protocols in the hospital, and actually when we were talking to Congress at the time, everyone wanted full disclosure on anybody with any problem in the hospital, and if you are a medical healthcare worker that's HIV positive, we demanded that you not be in our ward. But you can see now how this becomes a multiple issue, isn't it?
Yeah.
Right? It becomes an issue of confidentiality.
Yeah.
It goes, becomes an issue of competency. It becomes an issue of discrimination. It violates justice. It violates a whole bunch of things, doesn't it? And also, here's the thing. Okay, I'm a doctor. I have hypertension. I can't treat people with hypertension.
Right.
Right? Me at the time, I'm all about the protocol, and I'm still all about the protocol. Like you stated, if the person follows the exact protocol that everyone else does, would it matter?
No.
It shouldn't. Right? So why should there be full disclosure? How's this? I have a history of aneurysm in my family. Should that be known by everybody?
No.
Because any minute now, boom, I'm done. I could be in surgery, boop, aneurysm in my brain, boom, I'm dead, I'm done. But how is that? It doesn't come into play. But these are some things we can think about. Now, regarding the patient, let's look at that. We have to try to persuade to inform on the partner. Do they have to? Because AIDS, of course, is sexually transmitted. And in any sexually transmitted disease, we have to ask the patient, who are your recent partners? Does the patient have the right to tell you? No, they don't. Because again, it's full confidentiality. But we try to persuade them. And we have to notify the authorities for any sexually transmitted disease or any communicative disease. For example, my father-in-law contracted tuberculosis. He contracted it before he came to this country. So what he must do? He had to own up. He had to give names of neighbors on both sides of his house. He had to give the names of everybody living in the house and who regularly comes to the house. And the Department of Health had to do what? Check each and every person. CDC had to also look at the report to see that what? Every person who is even remotely in contact with my father-in-law gets what? Knows that he has full-blown tuberculosis. That was years ago. And then what they do? Follow up, you make sure to take all the medication, regular screenings for everybody, my nieces, my nephews, my cousins, who were all living in the house. All of them were eventually what? Negative. But that's what we have to do. Lastly, let's say if we know the partner of the patient, depending on the protocols of the hospital and some ethical considerations, let's say for example, husband and wife, right? We know the significant other as well because it's on the what? It's on the emergency contact form. So there's an ethical duty there. But again, back to the protocols of your facility. And if you don't know what they are, do you pull triggers? Do you go start informing everybody and start calling everybody because you'll also be involved, especially HIM, in the database. That means you'll know every patient, everybody that goes within the radius. All you have to do is a database. All you have to do is type Fairfax 22031 and boom. Every patient, everybody who has any dealings. Same thing with the Department of Health. I could just fill in the word diagnosis. I have every diabetic patient, in the system. That's what's kind of neat and kind of bad about electronic health records. It's fast, it's really cool, but now it starts creeping into everybody's business. And that's why we need you, HIM person. Because we have to make sure that no one gets full, unadulterated access for no reason. It has to be a reason. And the same thing with you guys. You guys could have a password to that same database. But guess what? She'll see it. She'll report it. So I always tell the story of MA. I fired one of my best MAs because she was running Mary Kay products out of my office. Not only using our mail, but she used our database to research every female patient from 25 to 45 years of age, and she used the database. How do I know? She printed it out, and when she was on vacation, someone called about, "Excuse me," yes, "Hi, I didn't get my order," and I'm like, "Maybe you were mistaken." "No, Lucy said," I'm like, "Lucy? My Lucy?" Then what do? We now did what? Had to initiate an investigation while she was on vacation. I opened up her drawers, and what did I find? Mary Kay products, mailing labels, and a list. We're using our printer, our database of all her customers. And also, she email bombed all our customers using our website. Well, so I had no choice. She worked with us for 3 years. She was awesome. Well, what was she doing? And she's on vacation, come back from vacation like all happy. And I'm like, sorry. And oh, by the way, the good doctor wants to file criminal charges on you. Because that's fraud. Thanks. She was like, oh, please, please don't. And I'm like, well, why'd you do it? Oh, I want to try to make a couple extra bucks. No, don't. I've had doctors. How many doctors like, oh my God, who's that girl? Who's that patient? That's where she lives? I'm like, oh, she probably goes to that one club. I mean, you can't do that. You can't, can't stalk somebody.
When I worked at the pharmacy at CVS, my coworker used to do that. Whenever like cute
Somebody's
guys
cute. Like, what are you doing? No, nursing. Everyone used to do it because the database all of us have IDs, and all we could say is, oh, I was researching on my patient. But nowadays, EHR and also HIM, they look at what I was sharing with you earlier, utilization. Like, who keeps on accessing weird patients? And the ethical board's gonna ask, Dr. Grice, why are you doing at 4 o'clock in the morning accessing these random patients that your name is nowhere in the chart? Oh, because he was cute. How many of my nurses got caught on ethical board because patient got released, then we see the patient come back, and I go, oh, you back in outpatient? No, I'm going to pick up Jane, we got a date. And I go, excuse me? I go, when did that happen? Oh, I don't want to get her in trouble. And I go, too late. Next time, don't show up in the ER with flowers. You know, I saw you 2 days ago. I know my brain is fried, but I remember you. And then I told her, does she know what you have? And I'm like, okay. But again, because they're cute. But if you're thinking about your patient and not about you, is anybody cute? No one's cute. I never, ever dated anybody on the job. I never, because ever, I've even looked at patient that way. Why? Because I'm focused on the job. But you see it in the hospital. Oh, especially Valentine's. It's so stupid that day. Come on, it's treated like a holiday, for heaven's sake. All right, next, we already talked about exposure, especially with blood. It's part and parcel. Now, for the administrative people in the room, not so bad, but you guys may be working in the same building, okay, or in the same floor. So, again, you run your protocols. Now, some facilities have restrictions, but most don't, because the American Civil Liberties Union years ago voted that it was it violates their rights. So there's no real restrictions. But how's this? We all live by the high standard, right? Everyone gloves up. And if you come into my MED230 class, what must we all, even though we're not playing with blood in the MED230 class, we must all assume what? Everybody in the room has HIV. Everyone in the room has what? TB and whatever horrible communicable disease. And that's also the same reason why, even though, you know, I allow you guys to eat, because probably when's the last time you eat, but typically we're in an OSHA regulated room. There should be no food, no water in here. Because what do we have to assume was on these tables? Blood. Bad things. But you'll see it in the hospital all the time. Like, you know, people noshing with, you know, the Doritos with gloves on. And they're like, oh, okay. Let me go see my patient now. And you're like, oh my Lord. Like, no, change your gloves. Why? No, they're already on. Oh, it's okay, I'm protected. Not you, genius. And it's funny, like, you know, how many times, like, I've had colleagues that got stains on their coat, and it's like, is that chocolate? You're like, yeah, I think. And I'm like, and even if it wasn't chocolate, let's say it was the other kind of chocolate, right? Let's say it was Duties. Change out.
Right, that's gross.
That's nasty. But you see it every day. And because, so again, all of this is moot. All this paragraphs is moot. Meaning to say is, because if you live by the higher standard, right? So, and it also depends on the facility. But let's look at here. Back to what we were talking about. Back to our ethos. I'm a broken record. Hello. Right? Err on the side of protecting your patient. Bottom line. For example, you have a really bad chest cold. You'll see some medical professionals put a mask on. I tell my patients when I have a really bad cough, oh no, this mask is for me. I mean, for protecting you. I got a really nasty cough, oh doc, you don't want to sit and talk to me? No, I don't. I don't want you to get what I got. Oh, why are you at work anyway? Well, because I got 67 other patients that I got to go see. But here, we have a policy here at Stratford. Any one of us gets sick and start hacking up phlegm, Ms. Ovette and Dr. Kerber was the first one to go, Nelson, go home. And the other day, I was in a meeting a couple months ago. I was, they're like, Nelson, out. Get out. Go home. Because why? I'm not protecting my team. Like, yes, it's all well and good that I want to help and I want to be on campus. Meanwhile, my lung is coming out of my nose. But it was the smarter thing to do is what? Stay at home. Maybe attend the meeting via a phone touch. Instead, no, I want a higher standard. That's not the higher standard. It's just being stubborn. So if you're in your facility and you're really sick, again, on-the-job protection is what? The higher standard. That will always protect you. There is a reason why I've taught phlebotomy for 15 years. I have no stick incidents. On EMS, I had one stick incident, but it was it wasn't a needle. It was I wasn't wearing gloves when I engaged up on a patient. That was like blood all over the place. Because what was I doing? I wasn't thinking. I wasn't following the protocol. And the other time I had a stick incident, my partner didn't communicate that she was behind me and she poked me with a needle, but the needle didn't touch any patient. She had already needle out and I felt, boom, I'm like, oh, did you just? And she was like, oh, I'm so sorry. I'm like, damn it! But that's what? That's a stick incident, even though it didn't have any blood on it. I have to write up a report and I have to, again, back to honesty. Remember our rules? I've got to own up. And she goes, oh, come on, it had no blood or anything on it. And I go, I don't remember her name. I'm like, Sherry. And he goes, you poked me with a needle. I'm bleeding. He goes, come on, gotta own up. So we get in so much trouble. She was a junior nurse. And I'm like, well, own up, and then don't make the mistake ever again. Here's the thing. Do you ever have somebody in the hospital work on you and start doing stuff on you? How many times I was in such a hurry, I took the wrong blood from the wrong person? I've done it a lot. Because why? I'm fast, I'm smart. No. I did not follow the protocol. Protocol states what? Remember I told you at JACO? Did you properly identify the patient? Did you make your identification known? How many times in the hospital, especially emergency room, people you don't know with no ID or with an ID that's flipped out backwards like this, start touching you. Hey, how you doing? Oh, boss, an arm. I get offended and go, whoa, whoa, whoa. Who are you and why are you touching me or my loved ones? So properly identify your patient. Properly identify yourself. Okay? Due to respect confidentiality, duty to respect, we already talked about that. Now, to tell the truth. Especially when it's what? Bad news. Prognosis. Those of you who have been in my medical terminology class, I'm not going to ask you for the definition, because every time I ask, it makes me sad. Pro means before, no knowledge, cis, process of. The process of before knowledge. It's prediction. I always hate these stories at dinner parties when people eventually find out I'm a doctor. I just tell people now, I make up a story like, who did I tell somebody last night? Oh, I'm a DJ and then I'm also a professional tree surgeon. I just make up anything other than medicine because I always hear this. Well, my aunt was diagnosed with stage 3 brain cancer and they said she had 3 weeks to live and she lived and she's still alive. What do you think about that? I always get that at first, right? Or because the doctor said my father would live at least a year and he died the very next day. What do you think about that? Take that in medical science. Like the first time, even when my friends introduced me when I was a first-year resident, my friends were so proud that we were at a house party and they introduced me as a doctor. And, oh, New York City's newest doctor, Dr. Nelson Grimes. Woo! Then a girl came up to me and went, "You killed my nana." Threw a drink in my face and then slapped me. Welcome to the wonderful world.
You didn't have nothing to do with that. She was
No, and also she was higher than a kite. So but it was like, I'm all high on myself because everyone was like, AMD, AMD. I'm like, yeah, that's me, what up? And I was going to DJ the rest of the night, like, ooh, right? I was going to be so happy, but instead, the girl goes, excuse me, you're the doctor? You're the one who just got to be a doctor? And I'm like, and I knew by the tone, like, this is not going to be a good conversation. So I'm already kind of backing up, right? And then then she gets in my face, you killed my nana. Splash, smack. And everyone was like, whoa. And then I'm like, and then people had the nerve to ask me, you just turned in the doctor, you killed somebody already? And I'm like, shut up, man. Because it's hard to tell the truth. You don't want to freak people out. No one wants to know the truth. How many times I tell them, well, you're obese. And they go, I don't like the way you said that. I'm not fat, I've always had this problem. And you can see how bad the conversation goes. Or, just even with my own wife, I goes, you have some mild hypertension. I am a certified Zen Zuba instructor. I eat so much better than you. I don't understand why you're telling me these things. And I'm going, this is the truth. I took your blood pressure for 3 days in a row. It's borderline, hence the diagnosis of borderline hypertension. No one wants to hear the truth, but we have to give it to them. But remember, planning on when to give it to them. But overall, the text says that what? Truth is always, remember, always the higher standard. But use it prudently on timing. And remember, prognosis is not the end-all knowledge. What is the end-all knowledge? Diagnosis. So the only thing I really should tell you is the diagnosis. And the prognosis, this is how I say it. Odds are, according to the textbook, this is how long you got. But we're going to be working on it so we can get your own number. That's my canned answer. Usually doesn't work. They still get pissed off when they say, 3 months? Or, I got to be on what diet? Okay? Now, you look at this. I love this. 98% of physicians surveyed had a policy of telling the truth. That's what they said. Or tell the truth eventually. But sometimes, remember, when you don't have the diagnosis, I will not tell my patient anything because I don't have the complete or thorough knowledge. And prognosis, I said, take it with a grain of salt. Why can't you tell us what's going to happen? Is my mom going to get breast cancer or not? And I'm like, odds are, the textbooks state, they're like, oh, you're just saying that to protect yourself. Yes. And also, it's the truth. So, keeping it to the truth, and because we have the duty to it. And my patient has the right for what? Full autonomy. How can you make a decision by yourself if you aren't given all the facts? Or all the relevant facts? Another thing that we also have to report to our patient immediately. Do laboratories make mistakes?
Yes.
Always. They're human. As long as it's run by a human being, it's going to get messed up. So you own up immediately. I don't say to my patient, well, the tech messed up. If the tech didn't mess up, why am I throwing the tech underneath the bus? I simply stated that the lab came back with inconclusive results. Would the lab messed up? I don't know. They may have or may not have. All I know is the laboratory asked me to repeat the process. Do you think that's telling the truth? That's telling the truth. But how many doctors or how many people are like, oh, the techs in the labs, sometimes, oh, that's the third one today. Why am I throwing, you guys, we're all in business, we're all in jobs. How many times have you seen that people done that to you? Throw you underneath a bus and throw other people, even if it's warranted. You shouldn't, because that's your team. And that is the what? The marketing for the entire facility. Let's say Stratford did something really messed up. I'd own up to it and say yes, and then do what? We are in the process of getting together to rectify this situation. Own up and say, we will fix it and we will do right by it. But hiding it, trying to blame others, or trying to say that, somebody, it's like trying to pass the buck or doing all that, is not ethical. Now, let's talk about telling the truth. Let's talk about Tarasov and the University of California. So pretty much, there was this guy, he was mentally ill, he goes to see his psychologist, and then he tells the psychologist that he is going to kill, I forgot if it was a girlfriend or someone really close to them, that he was going to kill this woman, Tatiana Tarasov. Okay? Now, we have confidentiality, we have patient's rights to confidentiality. What do you think, according to what we talked about so far, what do you think the psychologist should do? If someone told you, and you're the psychologist, I'm going to kill somebody today. No, seriously. I got the knife and everything. I got the rope. I went to, I went to CVS and I bought some really cool stuff that, drug her up before I do. And they told you the whole elaborate plan. What would you do?
I would tell.
You'd tell.
That's my ethics.
But there's confidentiality. Yeah, maybe he's just talking smack.
No, he crazy. Period.
Well, maybe he's just,
If you if
or
you
maybe
think
he's just very meticulous on his dreams.
he nuts,
Oh.
and I'm gonna lose my job.
Right? Or, okay. Well, the psychologist thought confidentiality. Like, you know, how many times you hear, like, oh, I'm going to kill somebody. And all of us in this world at one time, you know, said something like that. Like, oh, I'm going to kill that guy. And you say it as a, right? And it was said in confidence. Well, according to Tarasoff, is that the patient's rights and the patient was already now in breach of contract. Because the patient has responsibilities too, right? The patient has a responsibility to not break the law. The patient has a responsibility not to put me in a position where I'm privy to breaking the law. Because if we're laypersons and you know I'm going to rob a bank, guess what? You're accomplice. You knew what I was going to do, when I'm going to do it. Well, the psychologist knew what he was going to do, when he was going to do it. The psychologist had the right, and here's the kicker. The guy who killed Tatiana Tarasov wrote it in a letter.
Oh, so he ended up killing.
And he killed her. He did kill her. But the psychologist was saying, but that's confidentiality, I have to keep that to myself. Well, there are exceptions. Now we see that there's already breach of contract. Now we see that there's another ethic that supersedes the ethic of confidentiality.
So the contract is if we both have to benefit
That's right.
and we have to agree. So I don't agree with you killing somebody.
Yeah,
So I
and then
can't-
also, you don't agree because we're supposed to what? Protect life.
Right.
Not only life of the patient, life of everybody else. And the same thing for the AIDS patient. That's why that a couple years ago there was this guy, and he was like a ladies' man in the club, right? And he got AIDS, so his thing was, I'm going to give everybody AIDS,
Yeah, I saw that.
right? And there was several people who did that. Guess what? That's
You go to
manslaughter.
jail.
Yeah.
Well, the people in the facility did the right thing, and especially during the time in the 90s where the law was hazy, because that's confidentiality. You don't want to talk, you try not to talk about it, especially with AIDS, and everyone was so scared about it. Well, the people in that particular facility did what? Called the cops and said, there's this guy walking around, and oh, by the way, we got the names and dates and times, because he was proud of it. He told them right out, and he got 25 to life for manslaughter, because it's the same thing as what? Walking around with a hammer and hitting people in the head. Because of the technicality that it wasn't murder, because it's premeditated. He knows what he's doing.
Yeah.
He picks his targets, and he did what he did. I've had several patients who stated that that's what they wanted to do when they found out they were HIV positive. Oh, I don't believe my man did that to me. Oh, the things that they're gonna do. And I go, and after my patient calmed down, he goes, are you serious about doing these things? I already gave you a number for counseling. Do you understand? He goes, that other people will read this report. I will report exactly what you said. And then they calm down, like, no, I'm not gonna kill anybody, I'm not gonna do anything, and it's good. Because I really would hate to have NYPD detain you. Because I do understand, you had some bad news. And then, but what I have to do? Watch. I have to monitor, because do you think that patient could have done it? Because that particular patient was faithful. Well, she claimed she was faithful, right? Because remember, you can't believe. You don't know the whole story, right? Remember, there's in any situation, there's what? There's three views. View A, view B, and the truth. The truth will never be known. No one will ever know, right? But as a medical professional, we have to do it. And not really judge, because I have what? Protocols in place. And one of them is the Tarasoff protocol. You have anybody, and that also goes for what? Colleagues. You have a colleague get really angry about something and is threatening to do bodily harm or do something. One time, it was really nice because how many times I've had before I taught you guys, I taught you very not so good schools. And I had a student said, Dr. Correa, someone's going to slash your tires. And he goes, I don't want to be involved, but I know the name and I know when she's going to do it. So I thanked her because she did what? The ethical thing. And she told me because the person was about to commit a crime. I don't know why. I only gave her C-. I don't know why she was so upset. Right? And I found it very funny that the D student was telling me that the D student was doing something more ethical than a C- student. And it was midterm. Come on, you could C- midterms. There's other problems. You get other problems other than me slashing up my beautiful, beautiful car. But again, what happened? Right? Caught her. We wait. It was so funny. We're just waiting there. I was like, we're buying like, there she is, she's walking. And then we were like on little walkie-talkies. And then I was like, security. I'm like, yeah, that's her. And he goes, yeah, that's a knife in her hand. Thank you. And we called the cops and was expelled for what? For something silly. But all of it gets documented. And do you think you're going to have similar issues? Yup. But it won't be so dramatic. Patients' rights. You already talked about confidentially on their side. HIPAA, big, big thing. Health Insurance Portability and Accountability Act. You cannot talk about it at all. The only 3 reasons you could talk about a patient is 3 things. 1, if you're clinically involved. If you're part of the clinical team, you have to talk about the patient and write about the patient. 2, if you're involved in the billing, because the billing requires the diagnosis and the procedure codes. So you have to look into the clinical chart. And last but not least, logistics. I was sharing with you earlier that we do studies. Like, let's see, how many diabetic patients came on Thursday versus Tuesday? Should we have diabetic day on Tuesdays or Thursdays? I need to look into the chart. So, and that's a logistical thing. Logistics is, how the running of your business. Or, oh, I have more patients in the month of May for EKG, so I should order more EKG paper during that month. Right? That's logistics. And that's what HIPAA outlines. And accountability. It is enforceable. And I see HIPAA violations all over the place. When they start really enforcing that, it's going to be trouble. Self-determination, we already talked about. Autonomy, advanced directives. You can have somebody speaking on your behalf, and we're going to talk about power of attorney in a moment. So someone can have a proxy. Remember, if someone is non-compos mentis, if you already know that someone's a little bit off, you're going to have to start looking at the chart and start investigating on, hey, oh, Mr. Davis, where do you live? Oh, I live on 231 Mockingbird Lane. Where is that? Do you live in a house? Oh, it's a group home. That's already a sign like, thumbs up. Oh, okay. Do you have any somebody who's like, a residential assistant or something like that? And then you start digging a little bit more. But do you see my tone? Right? And then you start digging, and then it goes, oh my Lord, this guy's court appointed. I got to be careful, because even though I'm discussing things and I want him to be informed, there's somebody else who has to come into play. Same thing, right? With your very young patients and very old patients. Same thing for your patients. If you can tell, I always love telling this story. We had a patient that went through the entire day doing this. Yeah, yeah, So he was doing that to me, and it was the end of the day. I was the one who was supposed to do the discharge summary. And he was kept on going, yeah. I goes, okay, you have to take this medication. And actually, we were all speaking Spanish, so he was like, yeah. Guess what? Was he Spanish?
No.
No, he was just going, yeah. And he looked Spanish, and everyone else was speaking Spanish to him. So what did we all assume? An entire staff for 8 hours, we all assumed he speaks Spanish. And then I asked him in Spanish, hey, you like playing for the New York Yankees? He goes, yeah, you and Alex Rodriguez, you guys make a lot of money. Yeah, Okay, so I'll get back to you after I talk to the King of Mars, okay? Is that okay? Okay, listo. And then I'll call the nurse. Come here, come here. He goes, ask him something in English. Yeah. And he goes, watch. And then he goes, do you speak English? Yeah. Keep on doing that. Oh my God! You know how much trouble we all got into?
So
This guy, we even gave him meds. We really didn't even know what he had. Because why? Right? He should have had a proxy. We should have been able to identify if he was capable even to talk to us. So if you have one of those situations, and we're going to talk about how we check for competency. Well, let's talk about it now. One of them is mirroring. Actually ask the question. Let's say, for example, okay, you have to take this pill twice a day. So, and goes, take it in the morning and then take it at night. And then I ask the patient, okay, what did I just say? Well, doc, you told me. No, I really need for you to tell me. So if he goes, yeah, I take like 2 pills a day. And goes, so what happens if you miss the one in the morning? Well, I double up in the afternoon. Wrong. Right? Take the 30 seconds. Because how many times had a patient later on in the afternoon they overdose? Well, I missed the morning, and I knew I was going to be busy Wednesday, so I took like 6 of them. Is that bad? And I'm like, well, it induced a heart attack. Do you think that's bad? Whose fault is it? Not the patient's. My fault for checking to see if he was competent and to see if he really got the message. And one of those techniques is mirroring. Ask the person to do what? Spit it back to you. Yes, sir, I know it's stupid of me to ask, but what did I just say? They're going to be snide sometimes, and, well, you said take it twice a day. Hello, morning, evening, right before I go to sleep. How hard could it be? I go, wonderful, thank you. Then I could write in my chart, patient fully understands meds, patient has been endorsed, patient can be discharged. Instead of, yeah, Because it was funny, when we found out, he doesn't even speak Spanish. It was like from Russia or the Ukraine. And then when he finally left, I'm like, no svidanya, bye. And he goes, make sure to learn to speak Spanish next time you're in New York City. But you look really Spanish. You look like Juan Valdez. So that's what we started calling him. And his name was one of those names, it was like Carbo. So we were thinking, it could be Spanish. Like Carbo, Carbol, I don't know. Like, so all of us assumed. And not for 1 hour, 8 hours he was in my ER. And thank goodness that I used my what training? Medical assisting training. I mirrored it. And then when I asked him to spit it back to me, all I got, yeah. And he was very pleasant, he was nice and smiled. I remember that guy. I remember Juan Valdez for the rest of my life. Okay, patient, Bill of Rights. We already discussed all these. I'm going to jot down them pretty fast. Respectful care, right? You can't be a jerk, even though they're a jerk to you. Because remember, they're sick. Okay? Encourage to obtain understandable information. You can't use medical terminologies. I have to not only give the diagnosis, I got to give what I'm going to do to you and what may happen. That's why you have all those, those Humira commercials. Well, you could have bleeding on your eyeballs and your left ear. They have all these horrible things because by law, it's the patient's right to know that even if I cure your allergy, your eyes will bleed. Patient has the right to make the decisions. We give the options. Patient has the right for advance directive, such as a living will, healthcare durable power of attorney. The patient can do some written stuff in advance. For example, I have durable power of attorney. I have a friend of mine who's a physician. He will make my decisions, medical decisions, if I cannot. He is also my proxy, because I cannot trust my wife or the rest of my family, because according to them, they'd hook me up to all the wires in all the free world and leave me like all strapped. And no, I'm not going out like that. Me personally, it goes nothing extra. Because it's my time, it's my time.
At all, like not even a week.
No, there's certain situations that I outlined in my healthcare proxy and also in my living will, because I'm still alive. My living will is like 10 pages long because I figured out like every scenario that I could ever have of being brain dead. Because my own personal opinion is, if this is not working anymore, then I'm not me. I'm just a shell. That's my own personal. My wife, the exact opposite. She wants to be like cryogenically frozen and brought back to life in 3010. I don't know. She's supposedly a medical professional, but sometimes I question. Privacy, of course, we talked about that. HIPAA, very important. The patient has the right that what? That the communications will be treated confidential as well. That the 3 reasons that we discussed will be adhered to, and that's why we have HIM personnel. I'm always coming back to HIM because of you today. You guys are also the policemen and women who make sure that no one starts accessing our stuff for other reasons. Has the right to review these records, but they have to be done through due process. You cannot go up to the doctor, I want my medical records now. You have to sign the form, because Who owns the medical record? It is not the patient. It is not the doctor. It is the facility that owns the records. So you have to request it by due process from the facility. The patient has the right to expect capacity policies, reasonable response. They have communication. The patient has the right to be informed of the business relationships. If the patient asks, do you have affiliation with this, that, or the other thing, we have to own up. That's why I always give what? Alternative places that we don't have affiliation. So you have a choice. How many times my patients always tell me, oh, y'all are in cahoots. I'm getting surgery because you went to medical school with the surgeon. I'm like, no sir, I did not. But do you want another alternative surgeon? Maybe you don't like her. Maybe I can find somebody else. Maybe somebody who, went to the school of your choosing. We can help you find that because they have the right. Because I bet you anything, I'll tell you right now, 9 times out of 10, it's that kind of the reason why I'm giving it to somebody, because I trust them. And I trusted them because why? I went to school with them. Or I worked in a ward with them as another kind of professional. I've always been accused of sending a lot of people to St. Vincent's in New York City, because why? I had my EMS training there, because I had my my internship training there. Many of my best nurses came from St. Vinny's. So of course, but if they want someplace else, I will give them my other contacts in other places. And I even tell them, oh, I had my EMS training in St. Vinny's. Wonderful, wonderful people there. Great oncology department. But if there's anybody you want, because what do I have to do? I got to own up. Like, what do I, and that's always the good patient that says, where do you know these people from? Okay? A consent, we already talked about that, but they have to be of what? Sound mind and body, and especially sound mind and body at the time that they made their statements. Okay? Continuity of care. If I leave your care, I should be able to tell you, here are your other options, these are the other people. And also, I go on vacation. I cannot leave without endorsements. I think my time in medicine, I went on a vacation once or twice. Well, the second time is because my grandfather died, so that's not really a vacation. The first time, they actually called me back from Bermuda. I was supposed to have 5 days. I had 3. Why? Because my continuity of care started falling apart. Well, I had no choice but to go home early. Patient has the right to be informed of hospital policies, practice, related to patient care, treatment, and responsibilities. That is actually the form that no one reads. All of this is on the form that you sign when you go to the doctor's office and when you go to the hospital. Remember, if you're doing registration, the front desk, which any of you could in any facility, you guys are all trained for it. If the person looks at it and signs it, go, I'm very sorry, sir, madam, you really have to sit down and read it and make sure you know all your rights. There are some places that even they kind of quiz you. My pediatricians in McLean, they actually quizzed me. Sir, did you read those rights? And I go, yes, I did. He goes, do you understand the blah, 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 blah? And I go, yes, I do. Can you initial these boxes that state that you not only read it, that I asked you these 3 questions? Oh, yeah, sure. They even took it a step further to show that the front desk did their mirroring and did understand. Because let me tell you, how many times I've been in other facilities like, oh, I signed here, and then they're like, I even saw that the woman didn't even sign her name. We didn't explain it to her. She started signing her kid's name.
Hmm?
Yeah, she started signing her kid's name in all these little weird places, and I'm like, I was an MA going, what's up? But as an MA, 22-year-old Nelson, not so bright, so what did I do? Until we got audited, and they started pointing out, why is she signing in between the margins? I don't know. So, shouldn't that be a problem with you? And I go, is it? She signed in all the right spaces. But again, now that I'm teaching the class, now that after years and years of experience, you know that it's already a sign that your patient does not understand. Or how many times when the patient's arguing with the pharmacy, that definitely means they didn't understand. Because the pharmacy has to tell them a thing or two. That means what? Did you do your job? No, you did not. All right, now that's the patient's Bill of Rights. Here's the advanced directives. I already really went over them really fast, but you should know them. Living will, durable power of attorney, Uniform Anatomical Gift Act. That's when, you know, on the back of your license and all that stuff, when you check off the boxes, whether you want them to take your eyeballs or not. And again, back to, you know, how you feel about it. Me, I checked all of the above because I'm part of that, the world that thinks that you can't take it with you. I can't take it with me, so. But then just, there was a comedian who said, just imagine if you get to the beyond, whatever you believe in, and you found out that you could take it with you. So there's people walking around with like no heart, no liver. Just imagine that, like, oh man, I should have kept my eyes. Now I'm blind. But it's very silly to think of it that way. But because, and also, I also checked the box because when I did my laboratory research, when I used to pick up corneas from donors, it helped thousands of people see. It helped all these other people see, and also the corneas were free of charge. Or how many times that a lot of the research that we did through all these donated organs helped a lot of people, like thousands, tens of thousands, and numerous. So that's why when I got older, I'm like, you know, when I was in my 30s, I'm like, I'm gonna check the box, take all my stuff. And then my wife went, what's gonna happen? And I'm like, and I go, what do you, I always make fun of my wife, like, what do you want me mummified? You gonna make a statue of me, like, you know, statue of me doing gang poses in the door? Come on, no. Right? And do not resuscitate. Oh, that kills my wife. Well, I have a DNR. It goes for my DNR request is for any brain dead or vegetative state, and I clearly defined it on my living will. Don't you dare do CPR. Because of what I said, remember? In my personal opinion, my living will states that if I am not thinking, right? Now, let's say, for example, which I also outlined in my DNR, I'm like all stuck on, you know, I'm communicating through my eyelids. That's still me, okay? So help me out, keep me alive, you know, hook me up to a machine that can, you know, count how many times I blink. And I have also outlined modes of communication as well. But there are a whole bunch of other things, like, for example, dilated pupils, anisocoria, or uneven pupils. No, I don't want. And my wife says, well, I'll take you to court. I'll fight it. Don't be evil. That's horrible. I'm already all in pieces in some chair, in some bed somewhere. Because that's okay. Science will put you back together. I'm like, what? So now you're going to create a cyborg? Is what that's going to happen? It's not going to happen. And also, I want my money to be directly from my children. I don't want millions of dollars being spent on something that we already know that's not going to happen. It's not, me personally, it doesn't make any sense. But that's me personally, right? And that, just imagine if I didn't write it all down, what would my wife do? We'd have no money, nothing for the kid, nothing. Everything would be depleted just so she can say, oh, look, he's in a jar, in a chair, and, you know, he gets to blink a light like every 5 minutes. It's not the way to live, in my professional and personal opinion. But you could have varying degrees of other things. Durable power of attorney. I know how emotional my wife will get regarding my own health. So why did I have the durable power of attorney to my best friend? Because he's a physician and he has ice cold veins. He is a thinker and he's a doer. And I know he will make the right decision without any emotion involved. And he and I had lengthy discussions on what would happen. And one of those lengthy discussions, he goes, keep my wife away from the money. It's because the money is for her, but she will make emotional decisions. I know my wife, 20 years. She will make an emotional decision. That's what she does to me on her personal life. And I can't have that. And my wife's like, I'll get my own lawyer. I goes, you cannot prevent me. And I go, want to bet? He goes, I can't. And then he goes, I don't believe you got rich to be your power. He goes, I should be your power attorney. I'm your best friend. He goes, yes. And he goes, but I know how you get. Look how you're getting now. And according to her friends, that she already got a lawyer all in play already. To squash all of that. But I told Rich, I'm like, you be ready. You be ready because Millie's crazy. Right? And do everything fast, so just give her a chance to do stuff. It's like right now, it's all a joke to us. We all laugh about it, but you can only imagine if it happens. Okay? How much time do I got? 10 minutes. Good. I'll be wrapping up 10 minutes. Now, minor, 18 years old. An emancipated minor. Minors must have their proxy or in loco parentis. Let me. Nice tab right here. I have to get the permission of the parents. Is under 18. Now, remember, we have things that supersede. If the patient is unconscious and or in an emergency state, we must assume that the parents would want me to deal with that emergency. But once the patient is stable, in loco parentis kicks in as well. So let's say, for example, I have a patient, conscious, semi-conscious, got hit by a Mack truck. Do I wait until I find the parents?
No.
No. I stabilize my patient but then, with further surgery and further items, we must get the parents. And how many times it's so stressful because we can't find the parents, or they're just simply not answering their phone. They're not answering anything. Right? Now, there are also times where we find that the parents. I had an appendicitis patient that had signs and symptoms of abuse. Single parent. So what now? I have to report it, right? So I report it. Now, parens patriae authority kicks into base. Patriae means country. So the state or the government now takes custody. So now the state, whoever is the proxy, which is most likely the, what do they call that? The social worker who's there at the hospital, they're the ones who sign the form and clears me to do what I have to do, because that one little girl had to, needed an appendectomy. And I'm like, well, we're about to crate her dad away. Mom's nowhere to be found. What do you want us to do? He goes, well, parents patriae kicked into play. Social worker signed a release. We did appendectomy that afternoon. Because the parents were not fit at that particular time. Mm-hmm. I always wondered in loco parentis, but loco doesn't mean crazy in this particular case. Loco means like location, like your place. It's the parent's place or the parent's standing. Okay? But that's really rough, especially for stuff where the kid's in pain, but they're not in danger. That's the rougher stuff, like broken arms. I can't do anything. Like the kid's like, ah! And you're like, sucks to be you, little man. He goes, can't find your mom. So just sit there, like, and the arm's like, oh, I can't set it, I can't do anything. And it's not an emergency situation, they're not bleeding out. It's a closed fracture. I just watch that kid with the bent arm like all day. Just tone it down a bit. And he goes, oh my God, look at my arm. I'm like, yeah, I've been looking at it for the last 15 minutes. Can you please shh.
They did that to my daughter.
Mommy's coming, don't worry about it. But then it was like 3 hours later. He's, where's my baby? And she goes, oh my God, why you didn't do nothing? I'm like, because in loco parentis, I need your signature. Here it is. And then she's yelling at me.
Well, my brother and them were there, and they was like, you don't have to come to the hospital. I said, yes, I do.
No, yeah, all you have to do is call. Call it in.
No, it was their fault. She was there, and she fractured her wrist on both sides.
What, she felt like this?
I don't know what she was doing. All I know
Because that's usually why you fracture bilateral, because you're trying to...
She was playing on a tractor trailer tire dealing with them. They're so stupid. I'm so mad.
We already talked about informed or expressed consent. That's when I tell you. There's also, we already talked about the emergency situation of implied consent. Remember, it's implied that, because if you're in an emergency situation, that you want to be saved. Okay? So, here's a classic case. Let's talk about duty. Patient passes out right in front of the ER doors. It's not really on ER property. Do we do anything?
Yeah.
Yes. because it's implied that that particular emergency situation that they would want to be helped. So I had to get my butt out there, 19-degree weather, and then do what? Pick up the patient, grab the patient in, and then I was upset at the time because I forgot my ethics. Because I was out there having a cigarette, and they're like, Dr. Grimes, look at that guy. He's having a seizure. And I'm like, yeah, what's it to you? This hospital grounds, that's across the street. And then my attending goes, Nelson, go out there, damn it. And I'm like, and I got to go help. And it's good, because that person was dehydrated, and it wasn't a drug patient. It was a stroke. And I just assumed New York City, another addict, another homeless guy is passing on the street. No, it was just a normal guy who's trying to get to the hospital and didn't quite make it. And I felt bad about that for about 5 minutes, and then I went back to being my normal curmudgeon self. Patient signs consent form. Okay? Now, here's the doctrine of informed consent. We already went through all of this. Know these bullets. Know what I have to explain in an understandable language. Okay? Gathering consent. Two crucial components regarding consent. We kind of talked about it already, right? It's got to be reasonable information. Like, I can't give them dopamine protocols and the chemistry of why your drug is going to work on your brain, work on your big toe. It's too technical, yes? But many doctors do what? Many medical professionals, look how smart I am. No, wrong. And number two, like we drummed home, they got to be competent. And again, you must test for competency. And one of the things that we're talking about regarding the test for competency is you just simply ask them to mirror back what you just said. If they can't do that, or they mirror it back verbatim, word for word, you got a problem. All right? So if they do it word for word, like just mimicking you, you can tell. You know when kids do that to you? Right? And he goes, you know how to turn on the faucet? Yes. He goes, I know how to turn the faucet. You said you stand up and then you turn the faucet. Is that exactly what I said? Yes. And then what? The bathroom's all flooded. Why? Because you gave consent to the wrong person. I am so guilty of that so many times, me as being the good parent that I am. We already talked about this indirectly. We already talked about implied consent, remember, versus expressed. Now, let's talk about the exceptions and the refusals. My patient doesn't need to know the risks, right? That are obvious. Like, you could be risk for choking if you swallow a pill. Of course you can. If the disclosures are detrimental to the patient, like if it'll totally freak them out, especially with severe heart conditions and or severe mental health issues. If you know the patient has severe anxiety disorder, do you tell them every little topic, every little thing? No. Please do not do that. You're just going to freak them out. Just tell them the basics of what they need to know. Remember, in a reasonable speech. Nothing too fancy. And also, gauge your patient. If you see their pupils are getting up and they're looking at you like something bad's about to happen, what do? Stop talking. Right? You don't have consent with any of the things that we talked about. You don't talk about the risks. You don't talk about how you're going to do the post-operative. Like, oh, we're going to do the operation. But if you don't talk about what we're going to do to get you kind of back to normal, or if I don't talk about the instances where you might not come back, that's what I can't stand about the Department of Surgery. Department of Surgery never wants to talk about the what if, the big what if, like the percentage of you not making it. I don't like that, because then it makes everyone think, this is what I can't stand. Oh, it's routine. Really? So it's every day you cut into your body, I take stuff out, I put stuff in, then I sew you up, and then and then I give you these medications, both in your arm, and you breathe in medications that you might not wake up from. So that's routine to you. And every time I say that to surgery, they're like, well, that's correct. Well, we're violating what? Our ethic. Not able to elicit the cure for every patient. If the doctor says, oh, this works on a whole bunch of people, this works on everybody, the consent is out the window. Cannot guarantee successful results. The physician cannot guarantee successful results. But again, going back to the opposite, if the physician or medical professional starts guaranteeing stuff, that's like me saying, I guarantee you the sun will be out all day today. I can't do that. I can tell you the odds. Okay? And that's what a good medical professional can do. Tell you the odds. And say,